Good afternoon. My disclaimer is that I'm a perfusionist. I guess I'm the token perfusionist today. The past leader at Cleveland, perfusionists and two perfusionists. Who else is a perfusionist? Thank you for coming. The perfusionist at Cleveland Clinic, who was a leader last year, used to write to me, and he'd always start the email with, "Dear number 2, because we're second in U.S. News World Report behind Cleveland Clinic. So please go back and tell him that the perfusionist from Mayo showed up today. I'm also an officer in the American Society of Extracorporeal Technology, and today's the first day of Perfusionist Appreciation Week. Pretty exciting, huh? Yeah. So go home and tell your perfusionists that you appreciate them. We're trying to keep up with the nurses. Perfusionists haven't always had their place at the table with standard writing groups. AMSEC started a group called the International Consortium for Evidence-Based Perfusion. And we've been a pain in Dr. Ferreras' side, haven't we, since 2007. I'll talk a little bit about that. Here's what I am going to try and cover. Dr. Ferreras presented the case so eloquently and the statistics, and the more we hear these numbers, the more scary blood transfusions become to us, and we should know that. And our goal is to eliminate. It's not to minimize, it's to eliminate any blood product given in the operating room. And I'm going to discuss some of those issues. I don't want to bore you with the details, but I am going to talk about levels of treatment effect, A, B, and C, and also, as Dr. Ferreras knows very well, he's argued the subtlety of all of these, the classes of recommendations, consensus recommendations from panels of experts. And it's good to be on these panels when these decisions are being made and when expertise is being asked for. When these classes of recommendations are published. We use these recommendations to guide us in our practice. You heard Dr. Ferreras talk about just having a multidisciplinary team versus not having one is a level of evidence at B and a strong recommendation, or it's something we should consider doing and should do. There's lots of references. The first recommendations that came out of the Society of Thoracic Surgeons, working in conjunction with the cardiovascular anesthesiologist, the SCA, didn't include perfusionist input, nor nursing input. And we made an argument in 2008 and 2009 that our International Consortium for Evidence-Based Perfusion should be included in these standard writing guidelines. And I want to thank you publicly so much for letting us into that process, Dr. Ferreras. Here is a learning map, or the elements. We heard the word elements of practice. If you ever wonder what a perfusionist is doing, whether they're sitting back there casually behind the heart-lung machine, they're thinking about all these elements of perfusion practice. Down the left-hand side, I know you can't read this, are the responsibilities of a perfusionist while they're running the heart-lung machine or while they're in the care, participating in the care of a patient. And it probably is in this order. Communication, which is part of safety, and going down. And we look at timelines like you've seen from so many presenters this morning in the care path of a patient. And we think in these steps, and we have elements that have to be met and standards that have to be met as we move through these steps. And I've grayed out some of the boxes where we're just now starting to get evidence-based guidelines to guide us, standards to guide us in our decisions on what to do. When you get a bunch of perfusionists together in a room, you'll find a myriad of ways of accomplishing the same thing. And those that deviation or variance is starting to narrow and to go away as we do more studies. Our professional organization is invested in the International Consortium just for the purpose of identifying opportunities for standardization and collecting data. All these decisions, controversies, quite often are made by a single physician or a single anesthesiologist or a single perfusionist, and not always working as a team. And I would say that's still the majority. So some of the recommendations from our cardiopulmonary bypass learning map or elements of practice are how we ventilate the oxygenator, reducing hemodilution, as Dr. Ferreras just showed us, and then there's things like avoiding hyperthermia. As you know, we cool patients down and we cool them back up. And for the sake of time, we're often encouraged to really warm the arterial blood. But there's some patients who don't take well to their arterial blood temp above 37.5 degrees going into their brains. And these practice points have been reviewed by panels of experts reviewing the literature and then coming back with classes of recommendation on what we should do and where we should stop. What's the maximum blood temperature we should put into a patient's brain? And in our practice, we've selected 37.5 degrees. And we'll sit back there and we won't go above 37.5 unless we're highly encouraged by a surgeon. The other part of our practice is the equipment, the things that you see. And these are physical decision points. And you heard Dr. Faris refer to a couple of techniques. But these are the components of the heart-lung machine that we're dealing with. And we're trying to minimize that. We're trying to get down to a circuit that is so small, has such a small priming volume, and has such a small foreign surface that the patient doesn't know they're going on to a heart-lung machine. And all the systemic inflammatory response issues are minimized, and we're minimizing hemodilution, which is one of the major causes of the need for transfusion. And I'll talk about these a little bit more as we go along. This is what our heart-lung machine circuit looks like once it's set up. Cardiopulmonary bypass across the United States, even though it's being simplified, is complex. It is a little bit like flying an airplane. We use checklists, and now we have 2 people that come into the room at the beginning of the case and go over about 5 or 6 checklist points to make sure we set our circuit up safely and it's ready to go. And the surgeons can expect the same detail of setup and performance and preparedness from every one of our cases. We have 16 perfusionists going into 8 to 10 rooms doing 14 to 16 cases a day. So we have some unique challenges, just like Cleveland Clinic and Duke University and some other large centers, of getting everybody on the same page and sharing the same protocols and same shared mental images and mental ideas. We have a perfusion care plan that each perfusionist fills out for each patient. It guides us through, again, a lot of these issues that identify risks during cardiopulmonary bypass, and I'll share where that's taken us here recently. Here's some of the elements of our perfusion care plan. We prepare for a briefing, the simple things that we've always thought about, which circuit we're going to use, which cannulas we'd recommend if we're asked. And now we've added things like oxygen delivery. We've become so aware of minimizing hemodilution and how low can we go on safe hemoglobins during cardiopulmonary bypass, the nadir of the hemoglobin or the hematocrit in the operating room. We've changed the way we estimate our target blood flows during bypass based on patient need, lean body mass, their previous oxygen delivery, their previous cardiac index before cardiopulmonary bypass. And these are all lessons we've learned from large population studies. And granted, we might only catch 1 in 1,000 patients or 1 in 500 patients by doing all this work, but at least we've identified those patients before we go on bypass. These are pretty traditional or becoming traditional. I wasn't thinking about my audience. I put this in as our question. Why don't you go ahead and do this? Renal dysfunction is associated with a cardiopulmonary bypass nadir, DO2, oxygen delivery index less than blank. I should have asked, have you ever calculated DO2? That would have been a better question, yes or no. Let's take a stab at this. We've come to learn from reviewing the literature and also our International Consortium for Evidence-Based Perfusion has identified opportunities to become better perfusionists. A perfusionist perfuses tissue. We pump blood through or over tissue, which is carrying oxygen and washing away metabolic byproducts. Can we have the answer? Let's see how you did. The answer is 272. Not too bad. Thank you for playing. I'll talk a little bit more about it. So I'm going into this detail just to show you how our practice has changed in the last 18 months. We'll actually calculate what the patient's DO2 index is before they come to surgery. We'll get that information from their echo or the cath reports and their hemoglobin. And then we'll see what we're going to do when we get on cardiopulmonary bypass. So we'll calculate the post-dilutional hemoglobin. We'll look at the target blood flow we've selected, and we'll see how short on DO2 we are or might be compared to their baseline value. And we found that some of our patients have an extraordinarily high DO2, especially if they've been anemic or compensating for anemia. AMSEC recently has rewritten their standards and guidelines, and our new guideline number 10 is about gas transfer, and guideline 10.2 is about calculating DO2. So we put that in our national guidelines now, so more perfusionists should be doing that. Ranuzzi's group, in a large retrospective study of CABG patients at normothermia, came up with a high association between renal failure and a nadir DO2 index less than 272. So we've kind of gleaned onto that number and used it. Miniature bypass circuits are a challenge. All the 4 major manufacturers have come up with their mini circuit. Mini circuits require the anesthesiologist, surgeon, and perfusionist to practice and communicate. The patient becomes the venous reservoir. The circuits are very small. Air travels through them quickly. So there's a whole myriad of responsibilities and new ways of doing things. And very few centers across the United States, probably 4 in 100, have actually mastered the use of these miniature circuits. So what we've done with our traditional circuits, our old circuits, is we've made them smaller, and we've gone in steps to make them smaller. Again, with these 3 guidelines driving us, what we've done is we right-size our circuits in a prescriptive manner, our circuits and our oxygenators to the patient's size and to avoid hemodilution. We do use techniques like retrograde autologous priming, empty venous lines, vacuum-assisted venous drainage. But once we select a blood flow based on DO2 and the patient's baseline metabolic needs, we will select the right size circuit and the right size oxygenator. A lot of perfusionists criticize this technique because you need 2 or 3 different tubing packs and 2 or 3 or 4 different oxygenators on the shelf, but it's probably worth the effort, and I'll show you some of that data. We've been monitoring on a quarterly basis our use of these circuits, or our ability as a team of perfusionists to right-size oxygenators and circuits. And we've studied it on a quarterly basis. We've looked back at 3,825 patients at the end of the first quarter of this year on a quarterly basis. And you can see that these are not CABG patients. They're complex cardiac surgical procedures. Many of them, patients have had reoperations. There's many females in here who are smaller and have lower red blood cell masses. Every patient is a challenge in their own manner. Lots of sucker flow, deep hypothermia, circ arrest, and it's not just CABG operations. So when we miniaturize the circuit and go smaller and limit our ability to handle sucker flow from the field, it's a big deal, and one that calls for a lot of planning. The FX15 is from one manufacturer. You can do this with any oxygenator from any manufacturer. That's the right size. And this shows over our last 9 quarters our incorporation or the increased use of a smaller oxygenator, a 15, which has a rated blood flow of 5 liters a minute. And here's our percent increase in the selection or use of a smaller reservoir, a 3,000 cc reservoir versus a 4,000 cc reservoir. Again, less priming volume, less surface area. And here is the resulting increase in that hemoglobin nadir, the lowest nadir found in the operating room for that patient. And you can see that this right sizing of oxygenators in conjunction with other multidisciplinary, multimodal techniques to reduce or eliminate blood have helped us raise the hemoglobin nadir. Here's the percent of patients receiving no blood products during their hospital stay. A little bit different from that graph that you saw from Dr. Ferraris at the end. This is the percent of patients that have received no blood products. And you can see over the last 9 quarters, we've had a significant increase in the number of patients that leave the hospital without a blood product. And we've been pretty happy about this. It's not just the oxygenator rate sizing, the tubing rate sizing, it's a team effect. And it does have dollar values. Here is Q1 of 2011. We used in this body surface area group between 1.5 and 1.74 meters squared, we used about 1.8 units of red blood cells per patient. The cost per patient was $22.95. In 9 quarters later, we're down to 1.2 units of red blood cells per patient on the average. That was a significant decrease, a savings of almost $800. And for the 262 patients that we did in Q1 that fell into this body surface area bucket, we saved $200,000. And if you multiply that times 4 times for the year, and then there's another different BSA bracket over here. The good news about this is where women fall. This is where our smaller women patients fall. And our circuits across the United States, and Joe Utley identified this many years ago when he first started databasing, cardiac surgery circuits or bypass circuits discriminate against small patients and women. It's a real testimony to my team, our team at Mayo. On Monday mornings, we have breakout meetings where we talk about our results, we talk about the techniques, we talk about how we communicate, and we've been able to accomplish these changes through consensus and through peer pressure, things like that. One final comment here on hemoconcentration. Conventional ultrafiltration, the use of a hemoconcentrator, we believe in at Mayo and we use a lot, but there is a caveat that you might be able to overdo hemoconcentration. And we certainly have been studying that. Many of our patients have compromised renal failure or renal function before they come in the operating room, elevated creatinines. And if we take off too much volume, sometimes the ICU personnel will call us and say, our patient has a higher creatinine now than they would have. You took off too much volume during cardiopulmonary bypass. So we're learning how much is too much. When we studied 200 patients, about 30% of the increase in the creatinine we could associate back to the volume of ultrafiltrate during the pump run. The one randomized controlled trial in the United States showed that the change in renal function was not related to how much we ultrafiltrate during bypass, but it's a healthy discussion that goes on all the time. My PA friends up there are smiling at me. So we've gotten rid of the arterial line filter. The arterial line filter is now inside of the oxygenator. The tubing diameters are smaller. We use more vacuum-assisted venous drainage. We'll go on with empty venous lines in patients that are borderline on needing blood. We're looking at the use of centrifugal pumps versus roller pumps just to get rid of the tubing and the volume. There's a lot of pressure and communication across the United States. You heard the term microplegia. In our endeavors to drive crystalloid out of every part of what we do, including the volume that the anesthesiologists give before bypass, one option is to go to whole blood cardioplegic solution with high levels of potassium and other drugs, although this hasn't panned out to be level 1A. So, in summary, form multidisciplinary teams. And that's pretty much a no-brainer. You say, well, we do have multidisciplinary teams, we talk, but if you really focus in the teams and you study the literature and the recommendations and get your protocols concise and shared, we've shown in our hands that it makes a difference. And study and benchmark your practice. As Dr. Ferraris pointed out, total quality management behaviors lead to positive treatment effects for patients. Thank you very much. Our next speaker is Dr. Moon. He comes from St. Louis at the University of at Washington University. He's the Joseph C. Bancroft Professor of Surgery, Director for the Center for Diseases of the Thoracic Aorta, and he's your Secretary-elect for the American Association of Thoracic Surgery. Dr. Moon.